also not opening. It is there. The link is there. Hello, sir. Palanisamy, sir.
Hello, good morning.
Good morning, sir.
Good morning.
Yeah, we are doing some preliminary arrangements, and we will start the session at 10 sharp.
Okay, no
We
problem.
are already live now.
Okay, sure.
Okay.
A very good morning to all of you. Thank you for joining us for today's international conference on healthy aging and research organized by Vilas College of Pharmacy, Mysuru. I am Dr. Rosi Raju, the organizing committee member for International Conference on Healthy Aging and Research, also the assistant professor, Department of Pharmacy Practice, Vilas College of Pharmacy, Mysuru. Healthy aging is the process of developing and maintaining the functional ability that enables well-being in older age. Aging is considered more like the sum of its parts, a non-linear, multifaceted phenomenon that can be defined at the molecular, cellular, physiologic, functional levels and by disease state. So in this conference, speakers will be briefing about functional foods and nutrition for healthy aging, current perspectives of vascular aging in brain health, rasayanas for happy and healthy aging, and the research reviews related to the drug and disease-related effects on aging. Now, without further ado, we will turn the time over to today's first speaker, Dr. S. Palanisamy, Professor, Department of Pharmacy Practice, International Medical University, Kuala Lumpur, Malaysia. It's my privilege to introduce about today's first speaker, Dr. Palaniswamy Sivanandi. Palaniswamy Sivanandi is an eminent academic having more than 13 years of teaching and research experiences. He has more than 20 years of experience in pharmacy field. He has started his career as dispensing pharmacist in the year 1997 as a diploma pharmacist. In 2005, he completed his pharmacy undergraduation, that is Bachelor of Pharmacy, from Madurai Medical College, Tamil Nadu. In 2007, he obtained his post-graduation Master of Pharmacy in Pharmacy Practice from SRM, that is Sri Ramakrishna Institute of Paramedical Sciences, Coimbatore, Tamil Nadu. He has completed his PhD in the year 2003 from the prestigious Tamil Nadu Dr. MGR Medical University, Chennai, and good clinical practice licensure exam from Ministry of Health, Malaysia in 2014. He has published more than 75 research papers in various national and international index peer-reviewed journals and has been serving as chief editor and an editorial board member of repute for more than 10 international journals. Dr. Palanisamy has been awarded with Outstanding Researcher in Pharmacology Award in 2018, Education Leadership Award in 2019, Global Knowledge Management Award in 2020. His main area of interest are cardiovascular and diabetic medications, oncology, pharmacovigilance, drug safety monitoring, prescription auditing, clinical research and development, cerebrovascular complications and rehabilitations, clinical trials, patient safety, and false risk medications. We are happy to have you with us in this platform today, sir. Welcome to the International Conference on Healthy Aging and Research. So, sir, I also request and hope that you'll wind up the talk by 10:25 a.m. as we'll be having the inaugural program shortly next to your talk. Over to you, sir.
Thank you. Is it audible?
Yes, sir.
So I'll share the slides with you.
Okay, sir.
Is it okay? Yeah. Okay. Can you see the slides?
Yes, sir, it's visible.
Okay. So very good morning to everyone and welcome to the ICHR conference today. I'm Dr. Palaniswamy Sivanandi from the Department of Pharmacy Practice, International Medical University, Kuala Lumpur, Malaysia. Dear audience, kindly mute your mic, and if you're not able to listen and if you're not able to hear my voice, just raise your concern. I will check our system. Okay. So today I'm going to talk about the impact of polypharmacy in geriatric population. So what is the need to talk about the polypharmacy and especially the geriatric population today? So before getting into the topic, we will see some of the literatures or the studies published in various journals. And systematic review published in the Journal of American Pharmacy Association says that whenever the patient takes more number of medications, and especially in geriatric population, it greatly associated with the polypharmacy and polypharmacy related death. And another study on polypharmacy and gait performance published in the Journal of JACS says that from the American Geriatric Society, the polypharmacy are greatly associated with poor gait performance. So whenever the patient take more number of drugs, it may interact with each other. At the end, the patient may get poor gait performance. It is longitudinally associated with the gait decline and also the falls incidence. And another study published in the Gerontology Journal says that the polypharmacy are greatly associated in the elderly people with the mortality rate. Let us say, for example, when the patient takes 1 to 5 drugs per day, the chance for getting death is almost 51.4%. But at the same time, if the patient takes 6 drugs, the chance for getting the mortality or the death is 72.8%. What it says, whenever we take 5 drugs, 1 to 5 drugs, the chance for getting the mortality is 51%. If you're adding one more drug extra, and the chance for getting the mortality is 72.8%. And coming to another study published in the BMJ Open, the study says that when the patient takes 4 drugs, and the rate of falls per 1,000 person year is 166.8. But at the same time, if the patient takes 5 drugs, and the chance for the rate of fall is 174, but if the patient takes 10 or more drugs, and the chance for rate of fall is 220.8. So whenever we increase the drug one by one, it increases the rate of falls also. So coming to the polypharmacy and adverse drug reactions in the geriatric syndrome, the study says that many medications are known to increase the risk of falls, and whenever we add more number of drugs to the patient, especially geriatric patients, it increases the risk of falls as well as recurrent falls. How to solve this problem? So we can go for medicine optimization to avoid the polypharmacy. As we know that geriatric population may have more number of complications, comorbid conditions, and we don't have any single drug to treat all the conditions. So there is no other choice. They're supposed to take more number of medications. But whenever they take more number of medication, there is a possibility for more complications. So what we can do here, we can go for rationalization of the medications. So we can check the medication, we can check whether it is appropriate or not. Through this appropriateness, so we can reduce the polypharmacy as well as the polypharmacy related complications. So coming to this another study, there is a study says that the antihypertensive medications associated with low blood pressure and low systolic as well as diastolic blood pressures are greatly associated with the risk of falls. There are a lot of medications contribute falls or drug-related complication in geriatric populations. But here, the antihypertensive medication produces more number of falls when compared to other medications. You can see here, the antihypertensive medicine contributes 15.3% of serious fall injury in geriatric population. The another Washington Post says that the American older people takes more number of prescription medications when compared to other people. And coming to the global WHO global report on fall prevention in older adults says that we know that geriatric population means above the age of 65 years, and here the people above the age of 85 are getting more number of falls when compared to other peoples. So the number of falls are greatly increases with increasing the age above the age of 65. And in India and the global wise, actually we have more number of due to the advancement of the healthcare system and as well as the treatment, we have extended the life expectancy, the life years. So by the 2005, by the 2005, we can see the picture here. There are more number of people below the age of 50 or 60. But here you can see the picture. By 2025, we'll be having more number of geriatric population when compared to other years. So when compared to 2005, by the 2025, we'll be having more number of geriatric population in the global scenario, global population. Coming to the another picture here, it says the number of geriatric populations are gradually increasing each and every year. By the year 2020, we are having almost 10%, almost less than 10% of geriatric populations. You can see the red color mark here. And by the year 2025, we'll be having more than 10%. By the year 2050, we'll be having 15.9. By the year 2100, we will be having 2.6% of geriatric population in the global total population. This is the global data. But what about in India? In India, we have almost less than 8% of geriatric population now. By the year 2025, we'll be having 13.8. By the year 2020, we'll be having 2100, we'll be having 26.7%. When we are comparing these two data, we can see in India, by the year 2100, we'll be having more number of geriatric population. That is, 1 among the 4 will be geriatric population. And in the global scenario, 1 among the 5 will be geriatric population by 2100. But in India, we'll be having 1 among the 4 will be a geriatric patient above the age of 65. Coming to the working population age here, you can see the red color graph here. In the year 1951, we had 57.1% of working age group. Now we have almost the highest number of working age. That is more than 65% of working age group people. By the year 2100, we'll be having 52.8% of working age. So what it says here, this data says that almost 50% of geriatric population in the year 2100 will not be working. Only 50% will be working. So many people will be geriatric populations above the age of 65. And you see here the black color graph here. By the year 1951, we had almost 5.4% geriatric population, old age population. By the year 2050, we'll be having almost 20% of geriatric population. By the year 2100, we'll be having 32.2% of geriatric population. So almost 1 in 3 will be the geriatric people. If you're turning your head straight, left, and right, by the year 2100, you can see 3 older people. Okay, you can see 3 older people, and there are almost 1 in 3 people will be the geriatric populations. I will tell you the clear details later. Okay, coming to the Indian picture, the states in the south, especially the Tamil Nadu, Kerala, Andhra Pradesh, Telangana, Maharashtra, and Odisha will be having more number of geriatric population when compared to other states of India. So we have a lot of room for the development of healthcare sector, especially for the geriatric population in India. Coming to the Western Australian Falls report in 2019, the report says that every 20 minutes they have at least 1 fall-related injuries in the hospital. In the year 2016, they had almost 336 fall-related fatalities in Australia, Western Australia, but the number was increased to almost 26,338 by the year 2017. You can see in the year 2016 only 336 because the lack of the reporting system for the fall-related injuries. By increasing or modifying the fall-related reporting system, now they had 26,000 the year 2017. And in the same report says that is, there are more number of ambulances were dispatched in the year 2014 to 15 to fetch the fall-related victims when compared to the road traffic accident or stroke combined. And over half of this patients are above the age of 65 years old. Another report from England says that there are about 400,000 older people are admitted in the accident and emergency department because of the fall-related injuries. And in the US, 1 of every 3 adults over the 65 years of old having falls in every year. That is, if you're turning your head straight, left, and right, and if you see 3 older people, 1 among the 3 older people will get falls within a year. So this is very, 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 pathetic situation in the global scenario. And coming to the number of deaths in the global population, you can see the picture here. There are more number of men are getting death because of fall-related injuries when compared to women. And coming to here, there is unintentional fall injuries says there are more number of men are getting fall-related deaths when compared to women. Especially the fall-related injuries or death are more common in men when compared to white men when compared to white women. At the same time, the fall-related deaths or injuries are more common in black men when compared to black women. So men are always at risk. So coming to the polypharmacy here, we know that what is polypharmacy. When we are taking 4 or more drugs, that is considered as polypharmacy. There are a lot of definitions of there from each and every country, but as per the WHO, if you are taking 4 or more drugs, it is considered as polypharmacy. So when we take 4 or more drugs, it may produce a lot of complications. So finally, it may end with a serious illness. not only taking more number of drugs, even if you're taking a single drug in abnormal quantity, this also may cause a lot of complications. So polypharmacy as well as overconsumption of medications may cause greater problem in older adults. The polypharmacy is very common in geriatric population above the age of 65 years old, and 40% of geriatric populations are taking 5 to 9 medications per day. At the same time, there are 18% of old age populations are taking more than 10 drugs per day. So this inappropriate drug prescribing or inappropriate drug utilization among the geriatric populations contributes more number of hospital admissions. There are about 10% of hospital admissions in older peoples are mainly due to the fall-related injuries. Okay. So we know that what is polypharmacy. So when you are taking 4 or more drugs, it may interact with each other. So due to these interactions, it may cause a lot of complications. A study says that when you take 4 drugs, there is a possibility for 1 potential drug interactions. At the same time, if you take more than 8 drugs or 8 or more drugs, there is a possibility for 3 potential drug interactions. This may cause serious health issues to all the people. So apart from causing drug interactions, it may also produce adverse drug reactions to the people. So what is adverse drug reactions? So this is not purely related to the drug, it is purely related to the patient. So even though you are giving a normal quantity of drug to a patient, if the patient produces an abnormal response or unwanted response, that is considered as adverse drug reactions. So this is a response produced by the patient's body to a drug, even though you are giving at a normal dose for the therapy, for the prophylaxis or diagnosis or therapy of the disease, it may produce some abnormal response which is noxious or it may be unintended, and that response is known as adverse drug reactions. So we have different types of adverse drug reactions from type A to type U. I'm not going to talk about all these different types, but you can read it later. So it may produce adverse drug reactions as well as drug interactions. So when we are taking 4 or more drugs, or if you are taking more than 1 drug, it may interact with each other. At the end of the interactions, it may produce either beneficial response or non-beneficial response or complications. Apart from drug may interact with the food, drug may interact with the supplements, drug may interact with the medical conditions. Now we have a new findings, that is drug also interact with the medical device. Drug may interact with some of the medical stand, or it may interact with what is a pacemaker. So there is a new class of interactions, drug and medical device interactions. At the end of this interaction, we may get either decrease in action or increase in action, or it may cause adverse effect to the patient. Coming to the brief explanation about the different types of drug interactions. When we take 2 or more drugs, it may interact with each other. So the drug also interact with the drug, or drug may also interact with the food or food supplements. So different types of drug interactions. And coming to another type of interactions, whether it's clinically relevant or not relevant. We know that almost all the drugs may cause nausea and vomiting, but it is not clinically relevant, because a simple episode of nausea vomiting or mild episode of nausea vomiting is not clinically relevant. If you have severe nausea and vomiting, a frequent nausea and vomiting, it may produce loss of electrolyte imbalance, a loss of fluid. So this may produce a lot of complications to the body. Then that is known as clinically relevant. So based on the clinical relevancy, we can classify whether it is clinically relevant or not. Some of the interactions are beneficial and some are not beneficial. Let us say, for example, you can take for the pain, you can take aspirin as well as paracetamol. So but at the end, after taking these 2 drugs, we can get a faster recovery from the pain. It's a beneficial action. But at the same time, if the patient is having gastric erosion and you are giving paracetamol as well as aspirin, the patient may end up with gastric bleeding. So it is an adverse effect produced by the same combination. Based on the mechanism, we can classify drug interaction into pharmacokinetic or pharmacodynamic drug interaction. If one drug alters the absorption, distribution, metabolism, and excretion of another drug, that is known as pharmacokinetic drug interactions. If one drug alters the pharmacological action of another drug, that is known as pharmacodynamic drug interactions. And based on the severity of interactions, we can classify the drug interaction into either mild or moderate or severe type of drug interactions. And based on the effect produced, we can classify drug interaction into either synergistic or antagonistic. If the drug produces same type of effect, that is synergistic. If it produces opposite effect, that is known as antagonistic interactions. So these type of effect will be produced in geriatric population, and it may end up with serious complication to them. As we know that the polypharmacy in older adults are a very big problem now, and the study says that the average senior citizen in the United States of America takes 15 to 18 drugs per day, and they are the victim for the polypharmacy. So these 15 to 18 drugs comes from the prescription medication, not from the OTC. So they take 15 to 18 prescription medication and finally end up with the complications. And when we take more number of drugs, it may produce more complications. At the same time, if you have more complications, there is no other way we have to take more drugs. Let us say, for example, you have hypertension, atherosclerosis, and diabetes. Is it possible to treat all these three conditions with a single drug? No. We have to take more number of drugs to treat all these conditions. At the same time, when we take all these drugs, it may produce a lot of complications. So both are interrelated. We cannot avoid it. But we can reduce the complications associated with the drug through medicine optimization. Okay. Are all drugs essential for your conditions? Let us say, for example, now we have a common cold and fever. A common cold with a fever, runny nose, and cough. And you are consulting a doctor. How many drugs they will write in your prescription? We can see in your prescription more than 4 or 5 drugs. Let us say, for example, for your infection, they will write one antibiotic. For the runny nose, they will write one antihistamine drug. And for your fever, they will write one paracetamol. And because you are taking all these 3 drugs, there is a possibility for gastric upset. So one pantoprazole or H2 blocker will be there. Then you are taking 4 or more drugs, right? So there is a possibility for general weakness. They will write one multivitamin tablet. So there are 4 or 5 drugs will be there in your prescription. A proverb is there in the South. They used to say, if you have common cold and you are taking treatment for the common cold, you will get recovery within 7 days. If you are not taking any treatment for your common cold, you will get recovery within a week. So what it says that whether you are taking medication or not, you will get recovery within a week. But if your symptom is very worsen and if you are not able to tolerate the symptoms, then you can consult your doctor and you can get the medicines. Otherwise, it's not necessary. The study says that one among the 3 drugs are not essential for our conditions. Okay, so what will happen when we are taking more number of drugs? It may produce a lot of side effects. So the common side effects related to the medications are mainly related to the general health. It may produce a fatigue or weakness or muscle ache, or sometimes it may produce anorexia, nausea, bloating, or cramps, or it may produce constipation or diarrhea. And in geriatric population, it may produce an increased risk of falls and hip fracture because it may produce a dizziness or postural instability or orthostatic hypotension or hypoglycemia. And it also reduces the cognitive function through confusion, sedation, headache, or insomnia, or it may produce restlessness, agitation, or delirium. So through these type of side effects, if it produces in the geriatric population, they may get loss of postural stability and finally end up in serious health issues and falls related risk. So the polypharmacy can have negative consequences in our day-to-day life. It may increase the health of therapy as well as it may increase the pill burden. It may produce drug interactions and it also cause adverse drug reactions. Then if I'm asking you to take one medication throughout the year, you will take. If I'm asking 10 medications for a year, how many times you will take? Maybe you will take all the 10 medications for 10 days or maybe for 30 days or maybe for 1 or few months, right? After that, you will stop taking all the medications. Maybe you will reduce one by one. Gradually, you reduce the number of medications. Without informing the healthcare professionals, you will reduce it. So medication, not adherence. So whenever you increase the number of drugs, there is a chance for lack of medication adherence and dysphagia, misadventures, and it may produce functional impairment. In geriatric population, it may produce geriatric syndromes. Example, it may produce falls and cognitive impairment, urinary incontinence, impaired nutrition problems, then dehydration, constipation. So why I'm talking or stressing more about the falls today? Because this area falls are greatly neglected in most of the countries. Now only the UK, US, and the developed countries started focusing on the falls because in each and every family we have geriatric population. But this drug-related falls are largely neglected so far, and now only we started focusing on the fall-related injuries. Especially in India, the fall-related injuries or the polypharmacy-related falls are not at all focused. We cannot see even a single studies or publication in India related to the falls in geriatric populations because we are not focusing on the area. Okay, what will happen actually when we take the polypharmacy can have negative consequences on the health and independent living. So when the patient's taking more number of medication, it may produce negative consequences and it also lost the independency. Suppose let us say, for example, a patient after taking the medication, the patient fell down. So the patient loses the independency, the confidence, and they will depend on someone else. It also increases the healthcare utilization, and it also increases emergency room utilization, hospitalization, institutionalization, and it increases the death rate. So all these are mainly due to the polypharmacy. Okay, so what is falls? So whenever you are planning to sit on the chair, you may have some desire that you are planning to sit over the chair. If suddenly you slipped or you lost your instability, you lost your posture, or suddenly you fell down, what will happen? It may produce injury. So you're planning to sit on the chair, but accidentally you fell down on the floor, means it may end up in serious complications in all the people. But especially in the geriatric population, because of the weakness, because of the aging process, because of lack of health issues, they cannot maintain the gait. So lack of gait performance may lead to falls. How medicines can cause falls? The medicine can cause falls either through the sedation, or it may produce impairment of postural stability, especially in the geriatric population. It may produce hypotension, so lack of enough pressure. The hypotension also may produce giddiness to the patient. They can maintain the posture. Drug-induced Parkinsonism, visual impairment, hypoglycemia, then vestibular damage, hypothermia, confusion, and dehydration. So by through these mechanisms, the medicine can cause falls in geriatric populations. There are some of the diseases are greatly associated with the falls. Let us say, for example, neurological disorders like stroke, Parkinsonism, gait disorders, vestibular disorders, dementia are greatly associated with the falls. Then some muscular disorders like musculoskeletal disorders, osteoarthritis, joint deformities, then muscle weakness, and sensory abnormalities like visual impairment, hearing impairment, then cardiovascular disease like orthostatic hypertension, arrhythmia, syncope, anemia, diabetes mellitus, then sleep disorders. So a lot of problems or medical conditions are greatly associated with falls. So whenever you encounter any patient, if any of your family members have, any of your geriatric family members have any of this problem, you have to be very, very careful. And as a healthcare professional, when you treat any of these patient with any of these medical conditions, you have to be very, very careful, because there is a greater risk of falls. And there are some other medications can also cause falls. Let us say, for example, benzodiazepines, antidepressant class of medications, antipsychotic medications, anti-epileptics, anticholinergics, sedative hypnotic drugs, muscle relaxants. These drugs can cause falls. If you are a pharmacist, I know that most of the viewers are pharmacists. So if you're a pharmacist, when you're dispensing these medications, you have to be very, very careful. And you have to advise the patient, you are taking false risk medications. So you have to be very, very careful. So advise the patient as well as family members, there is a risk of falls among them. So they can be alert about the risk of falls. And there are some prescription medication that can cause falls. Let us say, for example, Parkinson's disease. Audience, can you please mute your mic? Some of the prescription medications like medicines given for the Parkinson's disease, cramps, painkillers, antihistamines, medicine given for epilepsy or mood depression also can cause falls. Apart from prescription medication, there are a lot of OTC medications like what we are getting from our pharmacy without any prescription. That is one of painkillers like ibuprofen, naproxen, some cold and flu medications, even allergy tablets, heartburn tablets, sleeping tablets. All these can cause falls. So whenever you dispense any of these medication, you have to inform the patient, especially when you are dispensing to the geriatric population. You have to inform them well in advance. How serious is the problem of falls? When the patient falling down, what will happen? Most of the time they will try to balance through the lower limbs. So the first area touch the floor is the lower limb. So most of the time patient will get injury of the lower limb. Whenever they fail to balance through the lower limb, they will try to touch the floor with the upper limb. So upper limb is the second most commonly affected area in the body, parts in the body. And next to that, the head will go down, so head injury, then followed by abdomen and thorax. So mostly we will be getting the lower limb injury and upper limb injury, followed by the head injury. So we have to be very, very careful. If the patient had any severe fall related injuries, it's a very, very pathetic situation for them. They will lose their independency. It will damage the entire disease progress of the patient. So what are the consequences of falls in the elderly patient? First one is mortality. If the injury is very, very severe, patient may get death. So there is a greater risk of mortality and morbidity like fractures, soft tissue injuries, head trauma, then joint distortion or dislocations and loss of confidence. Once they fell down first time, they will lose their confidence. Once they lost the confidence, they will not try to do any activities in the future. So fear of falling. So because of the fear of falling, they will restrict all their day-to-day activities. So what will happen? So if any of your family members have any fall incidents, or if they had any severe fall injuries like fractures or anything, then we have to appoint someone to take care of them. Otherwise, you have to quit job and we have to sit with them to take care of them 24/7. So it is not only a problem for the geriatric patient, it is a problem for the entire family members. So normally where they will get falls, most of the falls incidents are happening at home because we are not providing enough amount of provisions to avoid the risk of falls. You see, just go and check your home, where you are placing your table, where you are placing your the mat, where you are placing your chair or table or sofa. Most of the time you can see we are placing the sofa or chair or table in the walkway. So for us it is easy, we can take a zigzag, we can turn like a hairpin bend. But for the elderly people, for the geriatric population, how can they go like a zigzag manner? So they always try to go in a straight manner to avoid the confusion, to avoid the falls. But we are blocking their way by placing some ornamental plants, some pot or some tables, chair, everything, and we are blocking the pathway. So this is one of the area for getting falls, and also the slippery floors. And apart from the slippery floors, then the loose rugs. So a lot of problems are there for the geriatric population, and home is not safe for the geriatric population because most of the incidents are happening at at home. And public places, we don't have much provisions in the public places, so it is another risk area. And apart from that, nursing home, especially the bedside area, is one of the major risk area for the falls. Okay, what are the risk factors associated with falls? There are some intrinsic risk factors. It is related to the patients. That is age and the sex, female, and low mortality and fragility of the patient because of general weakness, functional impairment, poor gait and balance, then low body weight. And apart from that, the cognitive impairment or dementia of the patient, and some chronic illness like Parkinson's disease or visual difficulty, hypertension, and some medicines like tranquilizers, antidepressants, and previous history of falls and heavy drinking. These are the factors are greatly associated with the patient, and some of the factors are not avoidable. But what are the extensive factors? So these extensive factors, environmental factors, are modifiable factors. If you are modifying this, we can avoid the number of falls in geriatric population. One is polypharmacy. So as we know that taking 4 or more medication is a polypharmacy. If you are reducing the number of medications, we can avoid the number of falls, or through the rationalization, we can reduce the number of falls. And home hazards like the clutter, loose rugs, poor lighting in the stairs or hallways, then the lack of bathroom safety, also one of the problem for the falls. Then footwear, also one of the problem. Then busy street or elevated walkway are also contributing factor for the falls in geriatric population. Okay, how to prevent or minimize falls? How can we prevent? We can provide the personal prevention, like we can make the home very safe for the patients by reducing the hazards, and we can provide some balance exercises to them to make the hip stronger. We can provide some hip protectors, or we can increase their healthy lifestyle. And we can provide some of the assistant devices like hip pad or mobility aid also we can provide. Then we can provide some cans or walkers or wheelchairs. So these will reduce the number of falls. And bathroom aids like raised toilet seats and grab bars. So you can see the picture here. Even though we have geriatric people at home, we are not providing any provisions like this. So this is very, very small, maybe few hundred for this toilet raised seats. So because most of the time they are falling down on the floor, especially in the toilet, because of the impairment of the balance. Whenever they try to sit down over the toilet seats, they are getting falls. So to avoid this complication, we can provide that raised toilet seats, or we can provide some hand rails. This will avoid the falls. These hand rails are very, very cheaper nowadays, so you can buy and fix it at your home, and you can make your home very safe for the patients. And we can provide some intervention programs like exercise or physical therapy to increase the gain the muscle strength, or to improve the balance and gait. And we have to assess the home fall hazards. So is there any hazards in the home, like loose rugs or wet floor, or any obstacles in the pathway? So all these things we have to supposed to assess, and we have to check the lighting, everything. Then evaluation of medical conditions. So what are the medical conditions for your family members or the geriatric populations? And is there any possibility for medical conditions that related to the risk of falls? And how many medications they're receiving? Is there any false risk medications? We have to assess. Then we have to check their nutritional status. And also we can provide support groups, like you can make a group with your family members, or you can make groups with your neighbors. And whenever you go out, you have to inform them, I'm going out, he's taking this medication, for this medications, so please take care of them. So you can make some support group along with your family members. Otherwise, in the hospital, you can make a support group with the doctors or healthcare professionals, nurse, pharmacists, and to avoid the fall related injuries. At nursing home, we can provide physical rehabilitation programs, and we can educate the staff about the falls risk, and we can assess the environmental assess and modification we can do. Then reduce the medication wherever possible or whenever possible, and also reduce the physical restraints. So through this, we can reduce the number of falls. But as a pharmacist, as a healthcare professionals, we can play a greater role in medication optimization through the medication review. So whenever you do the medication review, then and there, if the patient is admitted in the hospital, you can review the medicines whenever you meet the patients. Either you can review twice or thrice, it's not a problem. So if you are periodically reviewing the medications, you can avoid the health hazards related to the polypharmacy. And if the patient is outpatient, and whenever the patient comes to your pharmacy to buy the medications, or whenever the patient comes to your clinic for the follow-up, you can review their medications. And if the medicine is not necessary, we have to remove the medications. And through this medicine optimization or medication review, we can reduce the number of falls or health hazards related to the polypharmacy. And there are 7 steps to approach the polypharmacy. First, you have to check whether these medicines are right for the patient. And if the medicine is right, you can give. And if there is any unnecessary medicine in the prescription, you have to remove it. Then you have to check whether this medicine are effective to the patient or not. And after that, and whether the medicines produce any harmful effects. If the medicine produce any harmful effect, you have to remove the medicine from the prescription. And also we have to check the cost effectiveness, because nowadays most of the medicines are very, very expensive, and most of the patients are not affordable to take the expensive medication. So you have to check the cost effective medications here. Then if all are agree, if all the healthcare professionals agree, then you can share the medicine with the patient, and you can monitor the patient's health outcome. And there are a lot of guidelines are available to optimize the medicines in geriatric population as well as the general population. There is a latest guidelines prepared by the Royal Pharmaceutical Society in the year 2018 for the polypharmacy guidance. By using this guidance, we can reduce the polypharmacy, and we can optimize the medicines in geriatric population. And apart from that, there are a lot of tools are available to identify the potentially inappropriate medicines, like start tool and stop file rule and crime and BS criteria. So there are a lot of tools are available. We can use any of these tool to reduce the polypharmacy and to reduce the medicine related complications. And coming to the tips for safe medicine use, keep a list of all your medication, whether you are taking prescription medications or OTC medications or vitamin or supplement, whatever you take, keep a list of all your medications. When you consult your doctor, bring this information to the doctor, and currently on this medication. So by seeing all these old medications, current medication, that doctor can optimize your medications, and they can give the new medications according to your requirement. Okay, and keep all your medicines at the same place, because especially in the geriatric population, the dementia, the confusion, memory loss will be there. So whenever if you change the medicines, the place of medicines where you are keeping again and again, they can't remember the place where they kept. So always keep the medicines in the same place, so they can easily remember, and they can take the medicines without any problem. Okay, thereby we can improve their medication adherence. And if you have any questions related to your medications, ask your doctor and about the medicines, and always use only one chemist whenever possible. Okay, why we are suggesting use only one chemist means, If you're buying this medicine in a pharmacy, because most of the time the geriatric populations are having chronic complications, they used to take the medicines for many years. So if you buy the medicine from the same pharmacy again and again, they will keep the stock of medicines. If you're not buying from the same pharmacy, and every time you are changing the pharmacy again and again, or chemist every time, if you're changing the chemist every time again and again, they think that you're not buying regularly, so they will not keep the medicine at the stock. So there is a possibility for run out of stock. And whenever you have shortage of medicines, you can't get the medicines immediately. So there is a problem for run out of medications. So that's why you have to use the same chemist each and every time to make the stock, and whenever you need, you can go and buy immediately. And take your medicines according to the direction given by the doctor, and talk to your doctor or your pharmacist if you want to stop the medicines. If you have any problem associated with the drug, and before stopping the medicines, just inform your doctor or the pharmacist, I'm planning to stop these medicines. Or if you want to add any medicines, that also you have to inform your doctor or pharmacist. And after taking your medicines, if you had any unusual change, let us say for example, you have fever for 10 days, and after taking a single pill, the fever completely subsided. It means there is an unusual change in your body. So you have to inform the doctor, after taking a single dose of tablet, my 10 days fever gone immediately. Means there is a problem. And after taking the medicine, if you had an unusual change or any worsen the condition, you have to inform the doctor immediately. Whether it is abnormal change, whatever may be the abnormal change, you have to inform the doctor. And throw away all the old medicines. If the medicine is old or if the medicine is out of date, you're supposed to throw it out. Okay, because the expiry medicine may produce a lot of complications to all the people, especially it may produce a lot of complications to the geriatric patients. And even though you and your friends or family members have same or similar type of symptoms, you should not use the same medicines. So let us say, for example, now we have coronavirus. The coronavirus symptoms are very common to the normal common cold, but the common cold is caused by the virus, what is a rhinovirus, and for the rhinovirus, normally it will subside automatically. No need to take many medicines. And if you have any symptoms, you can take severe symptoms, you can take antibiotics, or you can consult your doctor and you can take some medicines. But for the coronavirus, even though it is the symptom is same, but the virus is different, the organism is different, so we cannot take the same medicines. So that's why you should not share your medicines with your family members or friends. And coming to the summary of my talk today, the fall prevention is one of the main aim for the better health outcomes in older people. As I said earlier, we are focusing many diseases. We are focusing even diabetes, hypertension, atherosclerosis, many things we are focusing. But this polypharmacy related falls are not focusing nowadays. Only few countries started focusing on the fall prevention. So this falls produces a lot of impact on the health of geriatric population. So our main aim is to bring better health outcomes in geriatric populations. So hereafter, if any of your family members receives any medicines related to the false risk medicines, which is coming under the false risk medications, you have to closely monitor your parents or your family members. And if the family members have any of the diseases which are greatly associated with the false risk, you have to be very alert. You have to inform them well in advance. And polypharmacy is a greater risk for falls, so we can avoid polypharmacy through medication review. As a healthcare professionals, we can optimize. For this medicine optimization, you no need to do any very big study. Actually, if you see your parents are receiving any unusual medication related to the false risk medications, you can consult your doctor, you can ask the pharmacist for the better advices. So through the medication review, we can avoid polypharmacy, we can reduce number of falls. And if the patient is having osteoporosis, there is a greater risk for falls, and we are supposed to provide the preventive medication to avoid the falls in future. And always encourage the patients to use medication very safely. So this is our first step we can do. There is encouragement we can do to avoid the drug-related complication, especially the polypharmacy-related complication in geriatric populations. Okay, thank you. Please remember that patient safety is first.
Thank
Thank you, Dr. Palaniswamy. Thank you for a wonderful presentation. Rosie, I think we have already exceeded the time. Shall
Yes, sir.
we go with the inaugural ceremony?
Okay, sir.
We can take
Thank you.
questions later.
Okay, sir. Thank you, sir, for giving invaluable insights on the effect of polypharmacy in geriatric patient. So with that, we'll go ahead for the inaugural program of this conference. Once again, a very good morning to all of you present here for the International Conference on Healthy Aging and Research. Healthy aging is about creating the environments and opportunities that enable people to be and do what they value throughout their lives. So everybody can experience healthy aging. Being free of disease or infirmity is not a requirement for healthy aging, as many older adults have one or more health conditions that, when well controlled, have little influence on their well-being. So now I request Dr. Muthuraman Arunachalam, Organizing Secretary of International Conference on Healthy Aging and Research, AIMSC, University, Malaysia, for the introductory speech. Over to you, sir.
Thank you, madam. And good morning, everyone. And on behalf of Sarada Vilas College of Pharmacy, I am delivering my introduction speech. Myself, Dr. Arunachalam Muthuraman, and this international conference on healthy aging and research is organized by Sarada Vilas College of Pharmacy. And I'm thankful to Dr. Hanumanthar Joshi, conference chair, principal, Sarada Vilas College of Pharmacy. And also President Sarada Vilas Institute of Sarada Vilas Educational Institution, Sri B.S. Parthasarathi sir, and Honorable Secretary Sarada Vilas Educational Institution, Sri H.K. Srinath sir, and all other organizing committee members, Dr. Akalya Sharma sir, and Dr. Ellen Senai, and Dr. Dingra, and all other scientific committee members, technical team, and all members and participant delegates. Welcome to this conference. And this conference mainly focusing on healthy aging and related their research work. And so many people working on the aging related concept. And nowadays, this aging related complication is very serious issue in society, and including Alzheimer's disease, vascular dementia, and Parkinson's disease, like that various disorder it is growing up. So ultimately, this conference focus on multiple areas in the form of theme, that is metabolic disorder, drug discovery, natural products, traditional medicine, nutrition, translational research, and complementary alternative medicine. This all field how it is helpful to prevent the aging process or reversing the aging process. This is our main motive. And we are selected very eminent speakers in this research areas, and multiple speakers waiting for this topic related presentation, and it will be more informative and it will be useful for your current and future research work. And based on this information, I am welcoming all, and I am handovering to the conference chair, Dr. Hanumanthar Joshi. Thank you, one and all. Thank you.
Thank you, sir, for briefing us in detail about today's conference. Now I request Dr. Hanumanthar Joshi, Conference Chair, International Conference on Healthy Aging and Research, Principal, Sarada Vilas College of Pharmacy, Mysuru, India, to address for the welcome address.
Very good morning, everyone. And thank you, Dr. Rosie, for the nice introduction, and Dr. Muthuraman for all your leadership qualities. So good morning, respected President sir of our institutions, Secretary sir. The healthy aging is a regular phenomena. The aging has to happen. If one person is born, he has to become aged. But what is expected is we need to have a healthy and happy aging. Everyone expects it. So in this direction, the scientists all over the world, the doctors all over the world are working, working in this area to make it, a smoother one. So in this direction, Sarada Vilas College of Pharmacy has organized this international conference. First we thought we'll conduct, on our own, but then we had our wonderful friend, Dr. Muthuraman. We had a discussion from past few days, and we could identify some good speakers. We'll be having, the aura of speakers. For example, we have people from Harvard Medical School, then the University of Erlangen, Indonesia. We have people from West Indies. We have people from, almost all Gulf everywhere, including India. including Banaras Hindu University, then Punjab University. So the intention is to make the people aware of the issues associated with aging, number one, and another one, how to find some proper solution. This conference will be definitely useful if the researchers can carry some important points for for the research. So with this, I heartily welcome the chief guest of today's function, Shri B.S. Parthasarathi, the president, Sarada Vilas Educational Institutions, Mysuru, for this program. Welcome to you, sir. Parthasarathi, sir. And I also take this opportunity to welcome Shri H.K. Srinath, Honorary Secretary, Sarada Vilas Educational Institutions, Mysuru, for this inaugural ceremony. Welcome to you, sir. And I also welcome Dr. Ahalya Sharma, who will be joining us very soon, the organizing committee member. She is also the principal of Government Ayurvedic Medical College, Bangalore. And I welcome a very good leader, a researcher, and a dynamic doctor, Dr. Lakshmi Narayan Shanai, the organizing committee member, the director of Government Ayurvedic Research Center, Department of Ayush, Government of Karnataka, Mysore. And I also welcome Dr. Muthuraman Arunachalam, the organizing secretary of the conference. And he is also the professor at AMST University, Malaysia. I also welcome all the members of the organizing committee. And we have got, the group of speakers who will be deliberating, their research in these 2 days of the conference. I welcome them all because we have already crossed, the time allotted to us. So I will not take the names of all the people, but you are always in our heart and you are always in our team, because the intention is to give something to the society. So with this, I welcome you all. And very importantly, I welcome the delegates who have joined from across the world, not only India. So I heartily welcome to you all. And thank you for joining, this conference, and supporting Sarada Vilas College of Pharmacy. And not only that, all, the associations associated with this. So thank you once again. And I wish the conference a very grand success. Thank you.
Thank you, sir. Now I request Shri B.S. Parthasarathi, President, Sarada Vilas Educational Institution, Mysuru, India, for the inaugural address. Over to you, sir.
Good morning, everybody. I'm Parthasarathi, President of the Sarada Vilas Institutions. I'm extremely happy to find my very good friend Shana in this group. He's one of the best speakers I've come to know. I was born in HD Kote, which is surrounded by a lot of forests. 4 rivers run there in our town. That is the only town in the whole of Karnataka where you can find 4 rivers. And it is surrounded by very thick jungles. As children, we used to move around in the jungles. Our age would be around 8 to 10. We were not afraid of any wild animals, even though that was the best wild animal resort in our country. People from all over the world, particularly in those days when we were young, Britishers, Americans used to come there for shooting. You will be astonished to know, though we used to be there in the jungles days for it, no animal did anything wrong to us. The simple reason is they had enough food. It is because we have encroached their land. There is problem now, animal and man conflict. Having said this, see, if a man has to be very healthy, he must have very good water and very good surroundings. That made us, in our younger days, there used to be plenty of that. And at home, very good food in those days. Not now, not just like now. We never used to visit hotels at all. Never. Only house-made food. That has made us very, very healthy in our family. Not only that, if you see what has happened in our country, we have developed certain habits which were not there in the earlier days. We don't work out at all. Don't do that at all. You'll be astonished to know I was born in the year 1943 and now my age is 77. I keep very, very, very good health, though I have sugar. Every day I walk a minimum of 10 kilometers. Do exercises at home. Do praying and do some yoga. Particularly, this yoga has come to me during this COVID time, when we had plenty of time. So, keeping healthy is a very, very good thing. We have got to keep very good health. Serve the nation. In order to serve the nation, we have got to serve our army and we have got to serve in our police forces, which I have done. I am very contented about it. Thank you, everybody.
Thank you, sir, for the well-wishes for the conference. Now I request Sri H.K. Srinath, Honorary Secretary, Sarada Institutions, Mysuru.
Good morning, everybody. I'm very happy to associate with this international conference on health, aging, and research organized by the Sarada College of Pharmacy, a unit of the Sarada Education Institutions. The two-day sessions, which is beginning today and tomorrow, this is very much necessary in this pandemic times, since people do not come out. So I'm very happy to note that the Sarada College of Pharmacy is conducting this webinars throughout this month, and this is, I think, the 4th or 5th session. This subject of international conference on health and aging and research, there is a threadbare discussions by eminent scientists, doctors from all over the world, who will discuss some important issues, and in turn it will give a good message to the medical fraternity and the general public in the days to come. As the phenomenon says that natural aging is natural in human life, and as age advances, the wisdom of the man and the experience will count. So, to keep health in the age, as the age advances, is very important nowadays, especially in the developing countries where the medical treatment are very, very high nowadays. So, to keep healthy, there is a slogan, famous, health is wealth. And there is health, and there is also wealth. So, to keep the man healthy, he should be always in some activities, especially after the age of 60. There is the government retirement age of 60 years. But after 60 years, he should involve most in the social works, which will keep him engaged. There is as idle man is devil's workshop, they say. So he should be more engaged of the retirement, and the social bondage should be there, and especially in a country like India, where the monetary earning are very less compared to other countries, keeping the health is very important. So I, on behalf of the institutions, wish this international conference as a great success. And I think many of the delegates participating will give a good message to the world in the days to come. Thank you very much.
Thank you, sir. Thank you for the address. Now I request Dr. Lakshmi Narayan Shinoy, Organizing Committee Member, Director, Government Ayurvedic Research Center, Department of Health, Karnataka, Mysuru.
Respected Parsarthi sir, Srinath sir, Joshi sir, am I audible? Okay, so there is some technological problem.
No, you are audible, but you are not visible. Please.
No, sir, there is some technical problem, sir. So I will only talk now. So my hearty congratulations to Sarada Vilas College and Joshi sir for organizing such a wonderful webinar, international webinar. And this subject is more focused subject because Government of India 2016 health policy, they have focused geriatric care as one of the component of primary health care, and rightly pointed out by Parsar sir, because he said he was 77, but he doesn't look like 77. So I think you are 30 plus, sir. Because geriatric care is one of the important thing, and Joshi sir has rightly pointed out these things because it is a need of the hour. Once again I congratulate Joshi sir, Sarada Vilas College, Parsar sir for organizing such a mammoth webinar. So congratulations to you. Thank you, sir. Hello.
Thank you for addressing the conference. Now I request Dr. Halya Sharma, Organizing Committee Member, Principal, Government Ayurvedic Medical College, Bengaluru, India, to address about today's conference.
If you are able to join, we can proceed to the next agenda.
ನೋಡಮ್ಮ ಇದು ಆಗ್ತಾ ಇದೆಯಾ?
For a wonderful inaugural program. Thanks to all the dignitaries for making time and also wishing and well addressing for today's conference. Now let's move on to the second speaker of this conference on topic functional foods and nutrition for healthy aging, to be presented by Dr. K.V. Harish Prashant. So it's my privilege to introduce the second speaker, Dr. K.V. Harish Prashant, scientist in the Department of Biochemistry, Technology and Research. He has obtained chemistry in biochemistry from University of Mysuru, and PhD from biochemistry from CSIR, CFTRI under the supervision of Padma Shri Dr. R.N. Taranathan, scientist in carbohydrate research. Bengaluru, and later in the division of biotechnology, Lincoln microarray for genomic profiling of metabolic load during protein expression. Dr. K.V. Harish has more than 2,800 citations. He has also studied other carbohydrates like gums, and fortification studies, and transfer technologies to industries. Apart from various recognition and honors, in 2016, bestowed with Dr. M. Mahadevaya National Award with Silver Plate, instituted by All India Food Processors Association, New Delhi. And recently, in September 2019, he was awarded with Best Faculty Researcher Award 2019 with cash award constituted by Indian Chitin and Chitosan Society at Indian Chemical Technology, Mumbai. Apart from being a researcher, Dr. Harish Prashant, presently he is an advisor at Adi Chinchanagiri University, Nagamangala, Karnataka. Honorary Secretary, so he is also the Honorary Secretary of Society of Biological Chemists, SBC India, and he is the member for Mysuru chapter and Central Executive Member for Association of Carbohydrate Chemists and Technologists, India. Now I request Dr. K.V. Harish Prashant to deliver the talk. Over to you, sir. We will wait for 5 minutes till the speaker enters the room.
Dr. Harish, are you there? Yeah, I think Dr. Harish is having some technical issue. He will join soon.
Yes.
Meanwhile, it's for the Dr. Harish, are you there? I think he's joining. Dr. Harish?
Yeah, am I audible?
You are audible, but you are not visible. Can you please switch on the video? Yeah. Yes. No.
Okay. Now?
And, now you are visible.
Okay, thank you.
Welcome, Dr. Prashant. She has already introduced you to the audience. And,
okay. Yeah.
Please.
So I'll straight away get into my topic then.
Yes.
Okay. Before that, I want to thank the organizer for giving me this opportunity and platform, and Dr. Joshi especially, and organizing secretary Dr. Muthukumaran. And I before that, I'll just share. I'll take 10 seconds for sharing this because here I just wanted to know from Vinay where I have to go. There is a screen share. It is coming.
Okay, I would help you out, Dr. Prashant. You can see the two icons on your screen. One right. Is for video, one is the audio, other one is for screen sharing.
Yeah, that I clicked. It got entered, and there is a your share screen.
Yeah.
Okay.
No, whether your presentation is on the
desktop. Yes.
Yeah. Please open it. It will open automatically.
Okay.
Or else, see, you please open the PowerPoint.
Okay.
Open the PowerPoint.
Right.
And now you go for screen sharing.
Okay.
You can drag that file on the screen. Yes, you are in. Yeah, okay. Now we can click on the file. You can click on the file now. It will open. Yes, give it the slideshow, sir.
Right. Okay. sorry for that inconvenience, because this is the first time I'm doing in this webinar jam. So shall I proceed, sir?
Please, sir, please.
Okay. So before going into the topic, I just wanted to just show my institute, because it's a palace, and Vadiyars have been gracefully given to research activities from long time. The research being conducted in CFTRA at this beautiful campus. So this is the campus, and there is a main administration building. It's a mansion. So next, I'll straight away go to the topic for the today: functional foods and nutrition for healthy aging. Aging. Actually, the aging is nothing but a physiological changes which take place in our human body, which leads to senescence. And here there will be a gradual decline in biological function, as well as to adapt to the metabolic stress. That ability will be get lost. Then the process of aging actually brings about physiological and even the immunological changes, which influence our nutritional requirements. So, aging is a major factor for chronic disease. Among these age-related disease, cognitive as well as the dementia especially is very pronounced, and they are the concern, especially for the day-to-day public health, especially because it needs a long-term care and management with respect to the aging persons. So, what are the exact challenges, health challenges in an aging population? Actually, we know about the frail. Like frail is the one which 30% of the people have a high risk of this age-related disease, especially with the malnutrition or a lack in proper nutrition. And muscle wasting, it's a very serious cause, and it loses the independence, as well as it induces a lot of disability in the aged persons. And here, if you see, there is a cycle of frailty, and where the undernutrition or the chronic undernutrition results in the muscle wasting or muscle loss, and this in turn reduces the metabolic rate as well as the movement, and in turn again the energy expenditure get lost, and these turns in a cycle, and this has been called as a cycle of frailty. And this movement and good nutrition are very critical for a successful completion of aging. And cognitive decline is the more likely which has been affected with this frail. Next, what exactly the nutrition? Nutrition nowadays, even this unprecedented situation like COVID, we are hearing a lot about the nutrition factor, which is very important even now and after a post-COVID situations. And nutrition, this is just to get the students. Nutrition is been coined by the Latin, it has been derived from the Latin, and it means to nourish. This actually is a sum of all processes. It is nothing to do with the one proper function. Here, nutrition means it includes the nutrients, the metabolism of the same, and the use of them to support all through the life and all the functions of the life's processes. Nutrition may be also defined as the science of food and its relation, especially to the health. And it's a primary thing which plays an important role in the growth, development, and the body maintenance. Next is a word, nutrient is nothing but a food factor, and where specific dietary constituents, especially the macronutrients and micronutrients, comes into a picture. Macro means a larger molecules like proteins, carbohydrates, as well as fats. And when it comes to micronutrients, vitamins, minerals, and other nutrients will come into picture again. And when we see some of the key factor which actually associated for the child malnutrition, and what happens consequently to the child's health. So main factors here which I am showing is now main concern is about insufficient breastfeeding, as well as poor prenatal before the birth of child, especially during pregnancy. These are the things which is really causing a lot of malnutrition, because it is the symptoms, actually some of the symptoms may not show until these undernourished children gets into adolescence, as well as during aging. So this, along with other socio-economical factor, as well as during the growth, undernutrition and maternal health, that is also very important, because this generation to generation, this nutrition factor runs. The paternal and maternal health is very important for the next generation. So this consequently will affect the children's health later on in the later age, where they end up in a lot of neurological disorder, stunted growth, cardiovascular problems, obesity, diabetes. They end up in so many aspects, especially impaired cognitive and motor development. These days are increasing very logarithmically. So undernutrition and functional decline in aging. See, whatever happens in the childhood, these will result in the older persons. This consequence, as I told you in the previous slide, many of these diseases suffered by older persons is especially with the dietary factors. So it runs from their respective infancy. Older persons are especially vulnerable to malnutrition. So these persons, whoever have succumbed to that that kind of situation, they are obviously malnourished. So it has been estimated in another 10 years or so, the 20% of people over the age of 65 and a little older than that will certainly have a dementia. So 20% is a huge number. So a malnourished adult with dementia can start experience especially anxiety and depression. So this will cumulatively affect the whole aging process. So this naturally occurring aging compared to this malnourished or aging is very different. So effect especially with the nutrition on a neurodegenerative disease, because why I have chosen this as a particular, it's so many lifestyle disorders are there, but still I wanted to emphasize more on neurodegenerative disease here, because it is growing very, very in a huge scale all over the globe. And this disease, especially the loss of brain neurons and other factors, results in these neurodegenerative NDD, that is neurodegenerative disease. And incidence, which is showing as statistics, 17.2 million people globally, they are affected with this NDD. Among them, Alzheimer is the most common type of dementia, and we all know that when the patient gets Alzheimer, he or she will lose the memory, and it disrupts whole of their life. Again, one more thing is about Parkinson disease among neurodegenerative disease, and this is especially results in impaired mobility and inability to carry out activities of daily living. So this is results in systemic and local dopamine in the brain and include bradykinesis. So these lack in these things will have a progressive PD situation. So next is whether it is possible to modulate or treat these kind of condition, especially with neurodegeneration, by using functional food. So before going to functional food, why we need this functional food? The traditional dietary approaches, whatever we do, we have done a lot of research over the period of time, and we have seen traditional dietary approaches have resulted in very successfully resulted in treating the obesity and cardiometabolic disorders, especially by showing a lot of clinical data on that. But it is less sustainable, and I mean, the effect of the same is very long. The time required is very long, and it has a little compliance issues too. So difficulty to get adequate nutrition from the routine food, especially nowadays, it's very hard to get a proper nutrition out of our food. So, and also we may require this functional food because the environment is highly toxic. We all know we are entering into a very highly polluted environment, even though we accept or not, but we are still going ahead with that. And there is a lot of pesticide issues in the food. So these has increased additional requirement of the nutrients. And also natural ingredients also in the form of nutrients is required to strengthen the body, especially when the person undergoes or takes a lot of antibiotics as well as drugs. So side effect, to minimize the side effects of the drugs. So these nutrients are required in the form of functional food. Then what is the actually the all about this functional food exactly? So this is a food where a couple of ingredients, a couple or more of these ingredients in the form of nutrients has been added to a food, and this product has a functionality. So what sort of functionality it should have? It should promote the health, and it should have a capacity to prevent the onset of diseases, or to increase this onset as far as possible. So some of these biologically active and non-toxic compounds seem to have impact, or it may be a solution for treating all these ailments. And it also provides food very adequately in the sense what exactly and how much is required. For example, the fats, protein, carbohydrates, because many a time many people says you have to take a less carbohydrates, less fat. That is fine, but there is always body itself gauges. Individual body is very different from each other. So individually they have their own capacity to gauge, and there is something called bioavailability for every person. So this adequate food which is required for each individual in the form of functional food is also required, especially to boost the immune system as well as for all the cells to get survive. And one more thing is, recently there is a lot of functional food with the additional herbs. You can see, especially for the medicinal potential. We have a lot of products in the supermarket shelves, where now there's a tremendous demand for these kind of functional foods. So how these functional should be, like functional food should have at least these three additional conditions. In particular, especially the first one is, it shouldn't be a tablet or a powder or a capsule. It should be a food which contains natural ingredients. And next is, it should be consumed as a part of daily diet. It is not like something it has been scheduled. It can be consumed whenever it is required. And one more thing is about the particular function which gives you to regulate the body. So it has a functionality in it. What sort of functionality? It has to enhance the biological defense mechanism. It has to have a capacity to prevent specific diseases. I'm stressing here, it has to be prevent. It cannot be a cure or a treat. So it is not a treatment or a cure. Here it is like prevention and recovery from specific diseases as a supplements to recover fast. So these are the things, and also it should control physical and mental disorders. And these are the things when it is these functional foods have a functionality to show up, there will be a slowing of aging process. So can modified foods be considered as a functional foods? It depends. Functional food may include even whatever we are taking, conventional food, such as grain foods, vegetables, and nuts. But processed foods, like modified foods, such as yogurts, cereals, and whatever the products available, the processed, is all modified foods. Here, we have to know that regulation is a prime thing. Whatever the label they want to put for these modified foods, the claims, nutrient claims, especially related to various health benefits, it has to be a proper in a regulatory manner. And so this has been taken care, especially with FDA and FSSAI bodies. Another tricky area nowadays is about the food fortification. Of course, food fortification has been long. I mean, it has a history of a long time. When products, when it gets included with the vitamin and other nutrients, so this sort of food fortification is also now, it's a trend. Whether next question is functional food, whether this will prevent nutrient deficiency. Filling your diet, especially with a variety of functional food, both with conventional as well as modified foods or fortified foods, can help to ensure that you have a nutrients you need, whatever you need, and it may protect against nutrient deficiency. In fact, since the introduction of these fortified foods, especially the prevalence of nutrient deficiency has really significantly decreased around the globe, and we have a data all over the world for this. For instance, especially I'm just giving a iron fortified wheat atta or flour, where in developing countries or underdeveloped countries, it has really shown that decrease to the 50% of these anemic children or patients been taken care by these sort of fortified foods. And this fortification also has shown from previous years, like it has taken care of a lot of nutrient deficiency, which includes rickets, goiter, and so many birth defects which has encountered in previous years. So functional food provide a lot of important nutrients that can help against diseases. Again, one more thing is whether it protects against diseases. Of course, it gives nutrients, but how about whether these functional food protect against diseases? Yes, actually, some of the functional food which has a lot of antioxidants in it. We know every disease is the onset is always a free radicals accumulation. So these molecules will get neutralized by these antioxidants and help in preventing cell damage as well as certain chronic condition to not to get it prevailed. And including this as especially worked for as anti-diabetic in most of the condition to manage the diabetes. It cannot cure the diabetes, but it can manage the diabetes, especially by these functional foods. And even it includes the heart disease and cancer also certain time. In the initial stages, it has come into our rescue, especially with the cancer. Here, I'm just giving omega-3 fatty acids when it has been included in the functional food. It reduces inflammation and it gives the boost for brain function and promotes health. So the polysaccharides and other fibers which really promote better blood sugar control, especially in diabetes condition as well as in obesity. It can even reduce the fat. So these fibers are also when get included into a functional food, it has a very sort of protective nature for these some of the lifestyle disorders. Okay, next, whether it has again a protection against aging. There is a different perspective for this. I'll be just sharing with you some of the results who have. I'm just comprised of some of the results who have really done a long work on this, especially clinical research studies, where researchers have found the dietary intervention had no apparent beneficial effect, especially with the neurodegenerative disease patients. So again, I'm emphasizing here only the neurodegenerative part of the disease. Here, again, the despite nutrition supplementation, this has actually improved body composition as well as reduced the morbidity, and even it has taken out the mortality. But it has shown no positive effect, especially on cognition issues. And here just I'm giving you one instance why. Because EPA, when gets administered in a higher doses, it really affect the patients rather than improving. For example, if it gives higher doses, it converts into a toxic compound and it has a deleterious effect. Whereas when it is being given in a proper ratio, this will have a beneficial effect. So here I'm just giving you one table taken out from one of the worker, where here you just see the duration of years, how much time they have studied. The duration is all in the years. So years of study, and with so many what we call patients, they have studied and they have come out the most of the comments in the right hand side, which it tells no evidence of a beneficial effect, even for a this high merit what is called that absolute diet, what they call which contains everything. And if they have been given to the patients, this is especially after onset of diseases. So that is the key. So once the onset happens during the aging, all the diseases, this will not have the much beneficial effect in so many neurodegenerative diseases. Again, this list continues. Here you can see some of the people have worked for 15 years, 10 years, and it all goes in years. So I don't go into the detail. I just wanted to give you the glimpse. Like most of the nutrient studies, it takes a lot of time because they say what you eat for this 10 years, next 10 years your health will be like that. So always that is true with the food and the nutrition part of it. Again, there is a contradictory work which they have shown, where contradictory means it is absolutely right. Sometimes losing weight in patient, especially with who will be having this cognitive impairment, it is very harmful on brain function. You know why? Because there will be a sort of catabolic condition where there will be energy deficit, and it leads to the cerebral starvation, which is also been called as a type 3 diabetes. But other way around, where there is a higher BMI for patients, will have a slower progression of these diseases. So these are some of the well-documented results they have shown, where this kind of especially the energy is very important. We shouldn't cut down the energy for any these neurodegenerative patients. But the nutrition research studies, especially in the present trend, they mainly focus on prebiotics and probiotics. So probiotics has a favorable effect towards mental health and inflammatory markers, as well as it has an impact on insulin resistance. And it has shown a lot of importance, especially in neurodegenerative diseases as well. We know that now the brain, more than a brain, the gut is been called as a little brain. So it has a complete access towards the body through this vagus nerve, where even through these metabolites like GABA, the dopamine, that monoamines, the ACFA, that metabolites, that short chain fatty acids, what I'm meaning, and cytokines. These are involved extensively to bridge between the gut and the brain. And when the gut has a symbiotic sort of environment where there will be a beneficial bacteria dominating the gut. But in other pathogenic condition where it is been called dysbiosis condition, where pathogenic bacteria will dominate in the gut. So, and this I wanted to emphasize, this gut is just like a signature for each individual. Each individual gut microbiota is very different, and we have to protect ourselves. Even pushing a lot of probiotics unnecessarily to replace your own natural microbiota in your gut is also not recommended, according to me. Actually, there is a lot of debates on this, but still, it's my view. And prebiotics will be more beneficial in that way, where your microbiota will be intact, and whatever you are giving as a prebiotics, it will consume, and more beneficial bacteria will get into a system so that your health will be intact. So next is about the phytochemicals as functional foods. We know that there are a lot of functional foods. I'm just giving you here how these functional food nutrients get into the system and have an impact in a molecular level. Again, I don't go into the detail. Curcumin, we know it has a lot of impact, and there's a lot of work been carried out. So turmeric consumption daily is always beneficial, even in such a COVID-19 situation as well. So, and also there is a lot of bioactive compounds like polyphenols, saponins, carotenoids, alkaloids, many flavonoids. So, and even the fatty acids like omega-3, polyunsaturated fats. See, everything is required by the body. Okay, and whatever you consume, only thing is eat well and burn well. That is the best solution for reducing the faster aging or getting into a healthy aging. So this I just wanted to share here about what we are doing at our lab, but I'm not going in detail. I'm just restricted to this one slide where presently we are working on one of the molecule. It acts even as a nutrient, and it can be also formulated into a functional food. That is a low molecular weight chitosan, where a chitosan itself is not admissible, or it cannot be incorporated in most of the functional foods due to its high viscosity and huge molecular structure. But we have carried out a sort of process to bring it down to low molecular chitosan, where it is completely water soluble and you don't have to use any of the medium for getting it dissolved. So this is a patented process we have brought down, and we have checked many the qualities of this low molecular weight chitosan. It has even has an impact on bringing out the bringing down the tumor and all. So that is a different issues. Now we are also concentrating on whether it has any impact over the rotanin induced Drosophila flies we have taken as a model, and here we have checked how it is behaving about the locomotory dysfunction, and how the neurotransmitters have a effect on this issue. So this we have done, and we can really claim like these molecules have a real, better effect when it is being internalized. So this through diet only we are giving, and we are now working on mouse model also. With this, moreover, in healthy aging, the aging factors I told you, there are several, including dietary, genetic, and all. But signs of aging here in the slide, we can see that there is a like decrease in brain function, cognitive vulnerability, and there is a slow motor processing, and the activity gets slow. So these are the things. Again, the degree of disability, including cognitive, not only depends on genetic factor, it also mainly relies on the lifestyle and the environment, because wherever we have been exposed and how our lifestyle we take into, that is a more important thing. Again, as I told, lifestyle behaviors, and here I am emphasizing on good, nutritious, and relishing food, because whatever you take, daily eating cornflakes just by making a bad face, why I have to eat only for the health. No, actually, whatever you eat, you should relish it and burn it through physical activity. That is what it is, and it should be throughout the life, not in any part of our phase of life. It is throughout the life, and it is the first step to prevent chronic disease and disabilities in old age. So this is what I wanted to put forth. And present vital factors in aging, other than what we consume and what we are there is a lot of pollution. There's a lot of person get addicted to this cigarette smoking. Stress is a huge factor today. Everybody is encountering. Of course, this is related to, again, illness, and even the how much is required exercise, that is fine. More than that is also which leads to a lot of increase in free radical, silently killing a person. So hence, again, antioxidants becomes very critical in these times. There is a huge shift from nutritional aspect of food to functional food. That now it has become a pressing issue to get into the functional food, nutraceuticals, and supplements, especially dietary supplements. So this especially for dietary remedies for so many human pathological conditions. That is why there is an increased functional food in the market, and is even other than functional food, nutraceuticals, fortified, enriched food, foodstuffs. So these are all claiming for health promoting effects. How we functional make this functional food development? First, it gets because it is not easy to get, put forth some functional food as we are looking, we are seeing in the market. Actually, it goes like this. First, it gets conceptualized, and then product development will be there. And efficacy and safety, this is a very important. Efficacy and safety, especially in animals and human studies, is very much required. Again, the evidence of substantial effects, and it has to get published because everybody has to endorse for that. And health claim regulatory review has to undergo. And here, this is also very important. When consumer buys with any perception, he should have awareness and also interest towards this. This is not only just to push to the consumers, but they should have a complete awareness of what we are consuming. And this will lead to a lot of industrial growth, market, and this will get into a huge market revenues. So this is how the cycle of success of functional food, especially with the health promotion, goes. So with the concluding notes, what I want to tell is there is a huge research opportunities, especially in nutrition and health, and functional food offer a lot of health promises, and even prevent certain diseases, and encourage product innovation because each day we are seeing a lot of new products. As previous 15 years, 20 years back, we were not seeing so much of new products. Now daily, each day there will be a new innovative products, especially in the food sector. And whatever functional food you wanted to bring in, it should have a complete regulatory evaluation has to be done, because it should only the one which can protect consumers and their health, obviously. So later on, again, it shouldn't be one which can dominate it. It should be only it should help in filling the gap in nutrient intake, but it shouldn't replace the foods that naturally contains those nutrients what we are daily traditionally taking. So that is the last remark I wanted to tell, and I'll thank you everyone for patience listening, and if there is any question, I'll love to take it.
Thank you, sir. I delegate Borhan Najib Khatan. He's asking that as we are talking about nutrition, are there certain ages at which a body's metabolism is slowed down?
Obviously, this is quite obvious. When there is an adolescence, there will be a huge metabolic rate we'll be encountering. In the child, in infancy, the food habits are very different, because according to metabolic activity of the child, or wherever in the later part, it all depends. Even we talk about geriatric nutrition. So in the old age also, the nutrients or whatever the intake we wanted to have it is quite different. So there is a huge difference from stage to stage.
Thank you, sir. And there's another question. From Bhaveshar. Will it not be better to address in nutritional deficiency directly in context of deficiency detected than meeting it by taking functional food comprised of conventional and fortified food?
Yeah, of course. Whenever see when you actually that is what I wanted to emphasize. Market is fully pushing all the functional foods which is required or not required. And we are just consuming what others are doing. I told you, each individual health is very different. What they require, a nutrient is also relatively different. So each individual, what it is been required, see, body only, for example, if you are thirsty, the body only asks for water, right? So just like that, symptoms of your body tells you what is required at the right time. Okay, but you should be very aware and you should be cautious to know at that part of time. Okay, many a time. Yeah. Yes. Okay. Is that fine? That answers your question, I think.
Thank you, sir. Once again, thank you for this informative session about functional foods and nutrition for healthy aging. Very thanks to you, sir. So now let's move on to the third speaker of this conference on topic insulin resistance as a drug target in Alzheimer's disease, to be presented by Professor Dr. Anil Kumar, University Institute of Pharmaceutical Sciences, Punjab University, Chandigarh, India. So it's my privilege to introduce the third speaker, Dr. Anil Kumar. Anil Kumar is currently working as a professor in Department of Pharmacology, University Institute of Pharmaceutical Sciences, Punjab University, Chandigarh. His academic qualifications are MA Science, PhD in Pharmacology, MBA in Operational Research. He has been awarded with ICMR Award for Biomedical Scientist, Chandrakanta Dandiya Prize, Bharat Shiksha Ratan Award, IBRO Award. Boycast Fellowship, ICAD Fellowship, Riken Brain Science Fellowship from Japan. His area of research interest are neurodegenerative and neuropsychiatric disorders, Alzheimer's and Huntington's disease, depression, stress, possible GABAergic mechanism, diabetes and related complications, neuropathic pain and inflammation. He has published more than 120 research papers. He has guided 13 PhD theses and 35 postgraduate theses. He is a member of editorial board for 8 journals and professional reviewer for around 48 journals. So now I request Dr. Anil Kumar to deliver the talk. Over to you, sir.
Thank you, madam, for a nice introduction. Am I audible?
Yes, sir.
Yes, sir.
Okay. Thank you. First of all, I would like to thank you, the organizer, for giving me this opportunity to share my views on this topic. Although this is also a new topic for me because I just started from last 4 or 5 years back, started my research in the area of diabetes, which is one of the metabolic complications. So I thought it is better to know regarding the insulin resistance as a target for Alzheimer's disease. You know that Alzheimer is one of the neurodegenerative disorder, right? And it is growing day by day. And earlier we used to say that it is a problem of aged peoples. But nowadays, if you see the prevalence, it is also found in the young people also. Maybe due to the lifestyle diseases are like this, or our healthy work culture is like this. We are going through a different pressures, day-to-day pressures, and that is what it is. Basically, the precipitating factors are there in the genesis of Alzheimer's disease, right? Can I have a next slide first? Yeah. So this is the first slide, that is I'm talking about first what is basically the Alzheimer, then I'll try my best to connect with the insulin. If you see broadly, what I'm going to discuss is, as the title says, it is the insulin resistance, as a target in the Alzheimer, because Alzheimer is not a simple disease, it's a complex disease. People, they are using different kind of drugs, and the drugs which are used, none of the drug is able to cure the Alzheimer till now, right? So these are the drugs which are used symptomatically to treat the patients. And Alzheimer is a most common neurodegenerative disorder, which is basically cause the cognitive decline or cognitive dysfunctions. Mainly the memory is altered, and pathologically, if you see, what is basically causing the problem is the brain depositions of amyloid beta peptides as a saline plaques, and that is the results in the formation of neurofibrillary tangles pathologically, which is the main hallmark, or you can say which are the key identifying features, or you can say primary cause of neurodegeneration in the Alzheimer brain. Apart from this, if you see more deeper into this problem, you'll find this A beta, which is the main cause of the problem, is formed from the catabolism of amyloid beta plasmatic membrane protein of the neuron and astrocytes, and which is including the neuroinflammation, oxidative stress, protein misfolding, apolipoprotein, hyperphosphorylation of the tau. These are the other things which are also contribute to the precipitation of this problem, Particularly the main area which is involved in the Alzheimer is the cortex and hippocampus. Can I have next slide, please? So this, if you see more, can I have next slide, please? Yeah. So what I'm trying to say is, if you see the beta amyloid cascade hypothesis, so this is basically the A beta, which is a proteolytic fragment which is generated from the catabolism of amyloid beta precursor protein. As I said in the previous slide, it is different, but it is mainly there in the astrocytes and neurons, which is a major constituent of the amyloid plaques, Now, apart from this, the literature says the genetic studies also demonstrated that mutation in this amyloid precursor protein, presenilin 1, presenilin 2 genes are responsible for the deposition of A beta. So A beta deposition, which is the major cause, is having a lot of things which are connecting, and that will leads to the accumulation or deposition of the amyloid beta. That is what it says. So mainly the current hypothesis which is dominating in explaining the AD pathology is the amyloid cascade hypothesis. And this amyloid cascade hypothesis is also cause neuroinflammation, It is basically secondary complications are there which basically cause precipitation of other problems also. So amyloid beta tangles stimulate microglials. It is microglial is basically the defense, which is basically activation when there is an inflammation occur in the brain. So it is generate pro-inflammatory cytokines. And if you see the literature, you'll find people or pharmaceutical company, they are making the drugs which are targeting the pro-inflammatory cytokines, particularly the TNF-alpha. If you see, there are a number of drugs are there in the pharmaceutical company they are making, which are targeting the pro-inflammatory cytokines, particularly the anti-TNF-alpha drugs, And that is because the pro-inflammatory markers are the main things which is basically precipitate, So they are targeting the cytokines. Apart from this, so these tangles readily forms the dimers and polymers, which is a basically major toxic element for the neuronal death. So in the Alzheimer, what is there is a degeneration of the neurons, or you can say the neurons, they start decaying, So that is what the beta amyloid, which is start accumulating, cause the neuronal death. Can I have next slide, please? Now, let me come to the next slide, that is the connection. What is connection? As I said, the diabetes is linked with the Alzheimer, Now, there is two ways are there. It is basically nowadays people thinking or talking about the crosstalk. What is crosstalk? The diabetic patients, they generally more prone to have a Alzheimer disease. And in those patients, or in alternatively, those having a Alzheimer patients, they have also insulin resistance, So in both the situations, there is a common link is there. And that is what we can say that somewhere insulin resistance is involved in precipitation of the Alzheimer disease. And that is what this slide reflects as a chronic diabetes is also a chronic metabolic disorder, and there is no drug which can cure the diabetes. It is a drug which is there. Whatever the drugs are available, they are generally manage the diabetes, right? So in a chronic, as the diabetes is a metabolic disease, so it is characterized by, that it is a high blood glucose level, or it may be due to sometimes the insulin deficiency or loss of sensitivity to the insulin receptors. There are two things are there which is basically explain the type 2 diabetes. Now, what is the link with the AD? Now, both epidemiological and experimental studies, they suggest that insulin resistance, I'm again repeating, the insulin resistance is the type 2 diabetes is a risk factor for Alzheimer's disease. It means it is indicating that those patients who having a insulin resistance, they are more prone to Alzheimer's disease. Or in another way, there is also a talk that is called as the patient who is having a Alzheimer's disease, they also have brain insulin resistance. And that is what there is some common link is there. And now these are also confirmed by the different epidemiological or experimental studies. So this research demonstrates also there is a positive correlation. What is positive correlation? Is there is a positive correlation between the insulin resistance and the increased amyloid deposition in the brain. And nowadays there is tau phosphorylation, which is also basically linked with the amyloid deposition. I will discuss later on the subsequent slides, which has become the main identifying feature for AD load. Now, so what are the common pathways which is there in both the problems? Now, if you see the diabetic pathway, cellular pathway which cause the diabetes, and they are also involved in the Alzheimer. So what are the cellular pathways involved in the Alzheimer? Is insulin, like growth factors, the insulin receptor substrate 1 and 2, right? These are and also the certain kinases are there, like AKT and mTOR is there. So they are also there in the peripherally in the diabetes also, but these pathways are also impaired in AD patients. So that is what it is recently suggested, that any alteration in the insulin signaling or glucose metabolism in the central as well as peripheral system would contribute to the cognitive decline in diabetic patients. It means, so diabetic patients are more prone to cause Alzheimer's disease. That is what it is there. And that is what people now thinking, that can insulin resistance be a target to develop a drug for the Alzheimer's disease? So in the next slide, I have explained what is this, how this, all different features they contributing to the brain insulin resistance. Now there is an insulin resistance, we can say that is in the periphery, but in the brain also there is a insulin resistance is there. That is what is the name is there, that is brain insulin resistance. Now this picture is basically explaining, the increased A beta aggregation, which is maybe due to the APP or presenilin 1 and 2 mutation. It may be due to the plaques formation, and these increased A beta aggregation leads to the brain insulin resistance, right? Not only this, the brain insulin resistance also contribute due to the increased tau pathology, and tau pathology is also having a connection with the A beta aggregation. So there is so many links are there which are interconnecting, but what is the correct way of explaining is still not known. But different pathways which are interconnected, and that the people thinking that it can be used to exploit new drugs. So now comes to the what is the next part is I am explaining first in order to understand whether we can use insulin as a drug as a target. So one has to understand the physiological role of insulin signaling in the neurons. So in the next slide, can I have next slide please? So in the next slide, so I have explained briefly what is the physiological role of insulin signaling in neurons, because neuron is the main target which is affecting the Alzheimer's disease. You are aware that insulin is a peptide hormone which is synthesized or released from the beta cells in the blood vessel, which is well known fact, we all know. And this insulin is transported to the periphery as well as brain by crossing blood-brain barrier. It means insulin is also affecting the brain by crossing blood-brain barrier. Now, what is the role of insulin in the neurons? So insulin signaling plays an important role in the neuronal growth. Number 1. Number 2, synaptic development. Number 3, energy utilization, mitogenesis, inhibition of apoptosis. And these all important roles they contribute. Whenever these pathways or these functions are altered because of the insulin resistance, it may cause the precipitation of Alzheimer. Apart from this, when we say insulin, so insulin generally bind with certain receptors, and they basically regulate the downstream physiologically. So there are different kinases are there, AKT, just I explained in the previous slides. It is also affect the mTOR, it is also affect the ERK and GSK3 beta, MAP kinase, and these are all pathways which are basically a secondary, the cascades are there, which is essential for the neuronal survival in physiologically. So what is the important thing is one has to understand the role of insulin in the neuronal functions. So one can understand whether these functions are altered in insulin resistance or not. And second one, we can check also whether in Alzheimer patient, these pathways are impaired or not. That is what is explained by different scientists. So in the next slide, what is the role of insulin signaling in the brain? Based on these physiological functions, can I have next slide, please? So based on these physiological functions, so insulin signaling in the brain, what it does basically. So when the insulin enter into the brain and bind to the receptor, particularly the alpha subunit of the receptors, it activate basically the tyrosine kinase phosphorylation of beta units. So what it does basically, I briefly have laid down certain 4 points. One is activation of insulin receptor kinase pathways, which is basically involved in, which is required for the cell growth, synapse growth, and for cell repair and maintenance broadly. Second one, insulin receptor activation is also have a direct effect on neurotransmission, which is also important for the induction of long-term potentiation. You're all aware of what is LTP, right? And modulation of neurotransmission will also influence the memory formation, memory processing, and cognitive process, And third part, which is the next slide. So third part is the insulin receptor also alter neurotransmission, right? That is very important. And you all aware different drugs are there. Currently, glutamatergic drug is there, which is used for moderate to severe Alzheimer patient. You all aware of memantine, which is a glutamatergic drugs are there. And NMDA receptor is there, So it also alter the neurotransmission. And fourth is the insulin also increase energy utilization and suppress the induction of apoptosis. I'll come to later on what is the GLUT4 transporters are there, which is also influenced in the Alzheimer patient, Can I have next slide, please? So what happens? So based on this background, what happens in the insulin resistance in the brain? So what happens in the brain is, when we say brain insulin resistance, it is basically the condition. What is the condition? It is a condition in which insulin does not respond efficiently to the physiological level. It means insulin is there, but it is not responding. It is not able to bind it, maybe due to poor sensitivity. So insulin signaling impairment may lead to the abnormal neuronal function. So when we say abnormal neuronal function, we are talking about the connection or the synapse, so that the brain will coordinate easily. So it basically affects the abnormal neuronal functions, and this is the hypothesis that explain the role of insulin resistance in the AD. Apart from this, research data also demonstrate that the significant decrease in the gene expression and protein levels of insulin and insulin growth factors and other downstream molecules, which we have talked about the physiological role, right? So that is what the insulin resistance. So if you understand the physiological role of the insulin on neurons, then you can easily understand what is happening in the insulin resistance. So these secondary cascades or down cascade is altered, and that is what is the target. Now, what is the A beta and brain insulin? What happens, So when the A beta deposition, can I have next slide, please? So in the next, so what is there? As we know that in Alzheimer, there is a deposition of the A beta peptide. And what is effect on brain insulin then when there is a more accumulation of A beta? So both have the same, some sort of same binding. So first statement indicating that the both insulin and A beta, both are amidoglycinic peptide, and they are basically having they compete for the same binding site. And that is what is happening. Right? If since it means they are competing for the same insulin receptor. So this hypothesis suggests that the amyloid beta have a potential to resist the insulin in the brain. So once amyloid beta start accumulating, it basically prevent the action of insulin to this reverse receptor. And that is what it basically have a opposite, it basically prevent the action of insulin and resulting in the inhibition of the other downstream pathway that we have talked about in the physiological role. Right. Third one, as I said, that insulin also affect the glucose. So if you see, the literature says intracerebral injected A beta develops glucose intolerance, right, peripherally, and brain insulin resistance affect other mechanisms such as release of inflammatory parameters, as well as they also alter the GLUT4, that is glucose transporters translocation. They're also influenced. Glucose transporters are basically the energy, so how the glucose is moves towards the brain, cells. Now there is another factor that is there, which is the recently scientists has used, that is the recent report demonstrated that there could be something called as factor X. People do not know what is that, but they define something, that is factor X is there, which explain or which may be the molecule or pathway that will form a bridge to connect the A beta accumulation as a responsible factor for type 2 diabetes and the AD, the load. So that is what these authors suggest, that the factor X characterization will be the important parameter to develop efficient therapeutic target for load treatment. So how much load treatment means how much A beta is accumulating. Next. So the next slide I have explained is what is the role of GLUT4. Nowadays people, they are also targeting the GLUT4 as a transporter, as a target, So physiologically, you all aware GLUT4 transport is basically cause the transportation of glucose to the cytoplasm for its metabolism through the activation of insulin receptor signaling. So once insulin resistance occurs, the glucose transport will not occur, and that is what the problem is. So people, they are using, so cognitive function can be improved by increasing the glucose uptake through the GLUT4. So there are different drugs are being used, so therefore increased expression of GLUT4 in the hippocampus could be a potential target these scientists are thinking of, right? They're developing drug also as a glucose transporters, Although GLUT4 different types of GLUT transporters are also used for different purpose, but there is there, Can I have next slide, please? Yes. In the next slide, as I said, the tau phosphorylation also have a role in A beta deposition, and there is a insulin resistance signaling and tau phosphorylation. Is there any relation? So research says that the experimental studies demonstrated that tau phosphorylation is induced by the activation of protein kinases. And protein kinases, different kinases are involved in this AD pathologies or A beta depositions. So that is what say that the tau phosphorylation is induced by activation of protein kinase. So it suggests that the protein kinases are basically involved in the tau phosphorylation, and tau phosphorylation is involved in the A beta depositions, right? So that is what it says. So they are basically entailed in the neurofibrillary pathogens and upregulated in the AD. Apart from this, the studies also suggested that the insulin signaling impairment have a potential to increase phosphorylation of tau protein, So can I have next slide, please? So in a pictogram, can we say when brain insulin resistance occur, there is a neuronal death is there in the AD? So what is there is a common pathways which can explain broadly the neuronal cell death. So these are all pathways are there, which is basically well reported in the literature, and that is responsible for causing the neuronal death. If you see that there is an alter in the brain metabolism, because diabetes is a metabolic disorder, so they also alter the brain metabolism. They decrease the glucose metabolism, and they cause resistance, insulin resistance, right? And when the insulin resistance occur, it basically causes the alteration of amyloid precursor protein, which basically increase the A beta deposition, and then broadly we can say it causes A beta toxicity, which is involved in the neurodegeneration. Similarly, there is also another pathway which causes the tau phosphorylation. So tau phosphorylation also basically impaired the axonal Yeah, can I have next slide, please? Yeah, so broadly, if you see, we can say the outcome of insulin and neuronal insulin resistance, signaling. What is the crosstalk, So you can see that whenever there is a beta deposition is there, it causes insulin resistance, And insulin resistance is because of it causes reduced PI3K, it causes inhibition of protein, PKB, AKT, reduce GSKB, and these are all contribute to the AD pathology, So these are basically the downward cascade which are influenced because of the insulin resistance. And that is what the important thing is here. So there is a beta deposition cause insulin resistance, and insulin resistance basically further prevent or impair the downward signaling. Can I have next slide, please? Yes. So what is this? So the subsequent 2-3 slides, what I tried my best is what is a neuropathological process, or what are the different the conditions which also contribute to the brain insulin resistance, and that is explain the AD pathology. Now, if you see, you all aware that is in the previous slides I've explained A beta toxicity. So whenever the A beta toxicity is occur, it basically affect the insulin sensitivity, and then it basically affect the other insulin signaling neuronal survival or plasticity. Right. Similarly, there is a microvascular disease may also affect the insulin resistance. Oxidative stress also affect the neuroinflammation and other pathways. And similarly, there is a transition metal accumulation also affect the glucose uptake, and hyperphosphorylated tau, they also enhance the resistance. Now there is other things are there which can also be understood why this brain insulin resistance occur. So there are different metabolic hypotheses are there. What is that? There is a GLUT4 functions which is basically reduce glucose uptake that affect the AD. Insulin receptor functions, they alter. There is this cause the AD pathways alter. Similarly, there is a mitochondrial functions they alter, so that is also contribute to the insulin resistance. So there is a hyperglycemia is there, so that is also disrupt the removal of the A beta 42. So these are different metabolic alteration that contribute to the Alzheimer's disease by affecting the brain insulin. Next. So based on this, can I have next slide, please? So in the next slides, what I have said is, so there are different things which can be used as a therapeutic target, for the Alzheimer's disease, because these are the metabolic pathway which alter, and they contribute to the insulin resistance. Now can I have next slide, please? Can I have next slide, please? Yes. So what is that? If you see in the literature, yesterday I've just find out, there are a number of things are there, So if you see, there are different pharmaceutical companies, they are developing, the drugs by altering different pathways. That is what, how we can make new drugs for Alzheimer's disease by targeting different pathways. So they are targeting insulin receptor also, like like growth factors. Some patents have been filed. Some novelty is there. People, they are making it. These are the basis of the new drugs. So people, they are using the amyloid inhibitors are there. So patents are. I have given some patents numbers, although it is not a complete list, but some of the patents which have been filed in this novel areas. So that explain that these are the areas which can be exploited to develop a new drugs. Can I have a last slide, please? Yes. So in nutshell, if you see, what I discuss is the diabetes and Alzheimer, they are linked to each other. There are so many pathways which are contribute or complementary to each other. If the patient is having Alzheimer disease, it generally has insulin resistance. Or those patients which are already diabetic, they have is a risk factor of Alzheimer's disease in that patient. So that is what is there. So in the future perspective, what I explained here is, although there are different drugs are there for Alzheimer, but they are all used symptomatically to target, they are targeting acetylcholinergic pathway, NMDA, glutamatergic pathways are there. There are 4 or 5 drugs are there. The last drug which was developed in Alzheimer's disease in, I think, 2006. After that, there is no drug comes into for the treatment or management of Alzheimer's disease, because we are making some mistake somewhere. That is what we are not able to develop a new drugs. So that is nowadays there is a opportunity. One has to think some other novel areas in order to develop a drugs. There is certain mixed factors are there, risk factors are there, which basically precipitate AD. AD is not a one area, it is a number of factors are there which precipitate. So people they are using the GLP-1 agonist as the drug for AD, insulin resistance. The extendin 4 is also there. Pioglitazone is also people they are using, although it is a well-known anti-diabetic drugs, but they can be used. They are having some potential to treat the AD patient. So that is what all I want to discuss with you. That's regarding this, the insulin resistance as a target for AD. Next slide. Thank you. I would be happy if any questions is there. Although I've moved very fast because of lack of time. So that's what.
Thank you, sir. Thank you for giving valuable insights on the topic insulin resistance as a drug target in Alzheimer's disease. Thank you once again. There's no questions from the delegate side. So thank you once again. So next we'll move on now it's time for the oral presentation. Consequently, I call upon Mr. Vinay Babu Kola, Assistant Professor, Sarada Vilas College of Pharmacy, Mysuru, India, for oral presentation. His topic is harmful impacts of IR temperature gun during COVID. Over to you, sir.
Thank you. Good afternoon, everyone. Myself, Vinay Babu Kola, working as an assistant professor at Sarada Vilas College of Pharmacy. Today, I am going to discuss with you a topic called thermal staining effects on health. Okay, and in nowadays, because of coronavirus pandemic, we are using these non-contact infrared thermometers at a high volume, and we are using this to screen out the people who got high fever. But it doesn't mean that every person who got a fever is a COVID patient. So there are many reasons for body temperatures to rise. There might be any other underlying conditions as well. So, and there are some social media posts circulating widely and going viral, and which is causing much confusion in the public, that whether this infrared radiation is causing any damage to the pineal gland or not. So today I am bringing this social media confusion to your attention to make a discussion, to finally to make a conclusion on this, whether how to use and what to use and what not to be done. Okay, and coming to the claim, what is happening on social media? Infrared thermometers, which are held near the forehead to scan the body temperature without direct contact point, and infrared light directly at the brain's pineal gland, exposing it to a harmful radiation. So this is the claim which a group of people are doing. For this claim, there are other group of people, doctors, who are answering that infrared thermometers don't emit any radiation into the brain. They sense heat emitted by the body. They pose no risk to the pineal gland. So this statement is done by Dr. Harris Say from the Johns Hopkins University, Maryland, USA. So now we are going to see these two topics separately. We will see what is pineal gland, what are its functions, where it present, and then we see how our infrared thermometer works. So by combining these both, we can come to a conclusion whether this claim is true or not, whether there is an effect on the pineal gland or not. So our pineal gland is present in our endocrine system, okay, and it is also a part of the hypothalamus where your body hemostasis is maintained and body temperature and balance are maintained. So coming to the anatomy of it, it's a small body attached to the roof of the third ventricle of the brain, containing nerves that connected to the hypothalamus, which maintains our hemostasis, and 10 millimeter long, reddish and surrounded by capsule. This pineal gland, actually, in Hinduism, in India, we call it as third eye of a person. Why we call it as third eye of a person? Because depending on the sunlight and the light which has been absorbed by the eyes, it activates inside and it maintains the circadian rhythm, which is necessary for a person to balance his sleep pattern. So coming to the anatomy, it becomes atrophy after puberty and calcified. It becomes a cartilage of your puberty and secretes the hormone melatonin. So this melatonin is a major hormone which is majorly required to maintain your circadian rhythm. So the other functions of the pineal gland is involved in several functions of the body: secretion of hormone melatonin, regulation of endocrine functions, conversion of nervous system signals to endocrine signals, causes feeling of sleepiness, influences sexual development. And also it also got the coordinating circadian rhythm, which is the main thing. And as a timing signal to coordinate events, the light dark cycle in the environment. And this pineal gland plays an important role in the secretion of gonadotropin hormones and sex hormones. So coming to the topic of infrared thermometers. So we are discussing why, because we know the importance of pineal gland. If at all these thermometers are affecting the function of our pineal gland, what happens? We will lose our sleep pattern, and because of the losing sleep pattern, there may be an imbalance in the circadian rhythm. Because of the imbalance, there may be, because of the improper hormonal balancing, there may be the reduction of the immunity in particular person. So this may lead to the lead the persons to be the prey for the COVID-19 virus again. So we are using something in such a way which may give bad impacts on a person. Especially in the geriatric patients, where already they will be struggling to sleep because of many other physiological and psychological problems, and along with that, if we give the same, it will affect them in a high scale. So these are the types of thermometers we are using in our in this pandemic era. One is industrial thermometer, which focus the IR rays, and one other one is with a less infrared rays. But both works with emissivity principle. So the industrial one is only intended to measure the temperature of the instruments, which we can't touch, or where we can't reach to them. So we are utilizing those thermometers to measure the body temperature, where we are leading to a bad impacts of these thermometers. Okay, and coming to the working principles of these non-contact infrared thermometers will measure your body temperature. And why we are implementing these in this pandemic era? Because to reduce cross-contamination risk and minimize the risk of spreading disease. So yes, we have to agree, we have to reduce the contamination, and also we have to minimize the risk of spreading disease. So that we selected these thermometers. At the same time, we have to calculate the negative impacts of it at the same time. So coming to the normal things, normal body temperature, while typically 98.6 Fahrenheit or 37 degrees centigrade is considered as normal. But according to the other studies, they have mentioned 97 Fahrenheit to 99 Fahrenheit is acceptable. That is from 36.1 to 37.2. And according to WHO, they have given the statement that if any person reaching 36 degrees, you have to quarantine that particular person, and you have to suspect that person as a COVID-19 patient. So we have to think here whether that statement need to be accepted or not. At the same time, this non-contact infrared thermometers also got some limitations, and there are certain proper using manual which is not being followed in our day-to-day life by any of these institutions which are using these. So we have to make sure if before measuring measuring the temperature, the particular person's head is not covered with any of the head forehead coverings or any caps or anything which may influence your reading. At the same time, the person should not be exposed to the sun before measuring, and the atmosphere at that particular time where we are taking this reading must be at a controlled rate, and we must note that particular temperature where we are taking it, and then we have to compare that area temperature to the body temperature. Then only we can analyze whether that person is having above normal temperature or not. And the close distance required to properly take a person's temperature represents a risk of spreading disease. So we have to maintain a proper distance while you're taking this. Anyway, it is an IR race. It can pass for a certain distance. So better maintaining a distance, not going too close, which may give you, which may make you to expose to the virus. If the person who is taking the measurement has already already carrying a virus. And some of the limitations are those, for example, head covers, environmental, forehead, how I explained before. And we have to clean these thermometers on a regular basis with a disinfectant, not to be immersed in water or other liquid. We have to clean this on a regular basis, and we have to monitor and evaluate them on a regular basis whether they are working properly or not, because they are end of the day they are electronics, which may give funny results sometimes because of the low battery or because of the electrical disturbances which is happening within those electronics. And preparing for the person, we have to make the testing area very clean, and the person body temperature or temperature at the forehead test area has not been increased or decreased by wearing excessive clothing. This is the same point we have discussed. So here we come to the proper technique and improper techniques. The proper technique is the first image which you are seeing here. We are heading straight onto the forehead, and we are taking the reading. And if you are the wrong procedure, number one, if you are exposing the IR rays on the sides of the person's head, at the same time, it may lead to the eye exposure and also any other organs, because our head is carrying, we are carrying a very sensible organs on our head, which may become a prey, and we have to experience the other bad effects of them later. And third picture will show you the another improper way, where that lady is already exposing to sunlight, and her body temperature might gone 2 degrees already up, and we are taking the reading. So here we are taking an improper reading, because her actual body temperature will not be taken by the electronic device what we are using. And coming to the conclusion, WHO has posted this poster on their website as a myth, and they are saying thermal screeners cannot detect COVID-19 patient. That means measuring temperature will not help you to catch a COVID-19 carrier. We are only doing it to measure the temperature. So anyway, it is not helping us to screen or analyze particular person whether he is a carrier or not. So what is the need of this? So so finally, I would like to conclude by giving you a statement. Instead of going to the forehead thermometer temperature screening, better go on the wrist, which will give you plus or minus 1 degree variation, and you can easily analyze, and it will not affect any other organs like our head or our pineal gland. Thank you very much.
Thank you, Mr. Vinay Babu Kola, for sharing your reflective knowledge with us. So we have come to the end of the morning scientific session of this conference. Now let us break for a sumptuous lunch and come back at sharp 2 p.m. for the oral presentation and plenary talks. Thank you all. We'll meet at 2 p.m. afternoon.